Before studying about any systemic pathology, you need to know the basic anatomy of that system. And keeping in mind that you know nothing about respiratory system, first I'm going to teach you the basic anatomy of respiratory system, and then we'll get into the pathologies. So basic anatomy of respiratory system. First, the respiratory tree. So there's your trachea. The trachea, it bifurcates at the point of carina into primary bronchus, the left and right primary bronchus. They enter the individual lungs, the left and right lung, where the primary bronchus, they divide into secondary bronchus. Then the secondary bronchus, they divide into tertiary bronchus. And this marks the end of the bronchus. Alright, so there was your trachea, which bifurcated into primary bronchus, the left and right primary bronchus, which entered the left and right lung. Inside the lung, the left and right primary bronchus, they further divided into secondary bronchus. The secondary bronchus further divided into tertiary bronchus. After bronchus, you have multiple generations of bronchioles, finally reaching the terminal bronchiole. Now, terminal bronchiole is significant, and here's why. The part of the respiratory tract, I repeat, the part of the respiratory tract after terminal bronchiole is acinus. And acinus includes three things. Number one, the respiratory bronchiole. Number two, the alveolar duct. And number three, the alveolar sac. Again, I repeat, acinus includes three things: the respiratory bronchiole, the alveolar duct, and the alveolar sac, or simply RDS. Alright, so there was trachea, which bifurcated into primary bronchus, which further divided into secondary bronchus, which further divided into tertiary bronchus, which then gave multiple generations of bronchioles, finally leading up to terminal bronchiole. The part of the respiratory tract after terminal bronchiole is called acinus, which includes the respiratory bronchiole, the alveolar ducts, and the alveolar sac. Now the histology. Starting off with the histology of trachea. It has mucosa, submucosa, cartilage plus muscle, and adventitia. Mucosa has epithelial mucosa and lamina propria. The epithelial mucosa contains which epithelium? It contains the respiratory epithelium, which is nothing but the ciliated pseudostratified columnar epithelium. What is the significance? It has two important things. Number one, goblet cells. Goblet cells, they produce mucus. And number two, cilia. Cilia, they beat or row, they beat uniformly in rowing fashion. The submucosa, it contains the submucosal glands, which are serous and mucous glands. Then you have the histology of bronchus, which also has mucosa, submucosa, cartilage, and adventitia. Mucosa contains the epithelial mucosa, which is again made up of respiratory epithelium or ciliated pseudostratified columnar epithelium, lamina propria, as well as muscularis mucosa. It has an extra layer of muscle inside of it, made up of smooth muscle. The significance of which is that during asthma, there is hypertrophy of this muscular layer. As a result, there is thickening of the muscular layer, constriction of the lumen, narrowing of the lumen, and difficulty breathing. The submucosa contains the submucosal glands. These are the submucosal glands. Lung. So if you look at the lung parenchyma, you will see lots and lots of air-filled spaces, and these are your alveoli. Alveoli, they are lined by two types of epithelium, the two types of cells, type 1 pneumocyte and a type 2 pneumocyte. Again, type 1 pneumocyte and type 2 pneumocyte. Type 1 pneumocyte is flat and it allows for the exchange of gas. Type 2 pneumocyte, on the other hand, is cuboidal, granular, and it has two major functions. Number one, it is stem cell, that is, it gives rise to other pneumocytes. And number two, it produces surfactant, which reduces surface tension. All right. Communications within acinus. So there are three types of communications present within acinus. One alveoli communicates with another alveoli with the help of a pore present in between them. This is called the pore of Kohn. One bronchiole communicates with another bronchiole with the help of a channel connecting them. This is called the channel of Martin. One bronchiole communicates with an alveoli with the help of a channel as well. This is called the channel of Lambert. So there are three. AAP, alveoli communicates with alveoli with the help of pore of Kohn. BBM, one bronchiole communicating with another bronchiole with the help of channel of Martin. And BAL, the bronchiole communicates with alveoli with the help of channel of Lambert. So with that, we are done with basic anatomy. Now the pathologies. Under respiratory pathology, we are going to look at the obstructive pulmonary disease, the restrictive pulmonary disease, the pulmonary infection, and finally the bronchogenic carcinoma. Starting off with obstructive pulmonary disease. Under obstructive pulmonary disease, we have four major diseases: chronic obstructive pulmonary disease, asthma, bronchiectasis, and bronchiolitis. Under chronic obstructive pulmonary disease, we have emphysema and chronic bronchitis. Both of them have strong, or shall I say very strong, association with smoking. Starting off with emphysema. Emphysema. Number one, definition. Emphysema is permanent damage to acini. See, so the emphysema is the pathology of acini. Acini, what is acini? The part of the respiratory tract after a terminal bronchiole is acini. It includes the respiratory bronchiole, the alveolar duct, and the alveolar sac, or RDS. Alright. Permanent damage, what does it mean? Remember the three words, the three terms, alright? So there is destruction of acinus, there is dilation of acinus, and there is fusion of acinus. Remember these three terms: destruction, dilation, fusion, destruction, dilation, fusion, destruction, dilation, fusion. Alright. Etiology. The most common etiology for any chronic obstructive pulmonary disease, be it emphysema or chronic bronchitis, is smoking. It's smoking. The other are environmental pollution, occupation, genetics, occupation like occupation acquired diseases like pneumoconiosis and stuff. And the specific cause for emphysema is also alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. Okay. Now pathogenesis. The pathogenesis is described by protease-antiprotease hypothesis. Before getting into the hypothesis, here's what you need to know. The alveoli present inside your lung is just like a rubber band. What do I mean? So when you pull a rubber band, it stretches, and then you leave it, it recoils back to its original configuration. Why? Because it possesses the property of elasticity. And what is elasticity? It is the ability of a substance, an elastic substance, to regain its conformation as soon as the deforming force which was initially being applied is removed. Itna to physics aata hai na, right? You know this much physics. Deforming force is removed due to elastic property. The elastic substance, it comes back to its original position, original configuration. Just like this rubber band, you have your alveoli. Inside alveoli, there is filling up of gas. As a result, the stretching of the wall of the alveoli takes place, and the alveoli, it dilates. After maximum stretch, it recoils back to its original configuration. Now this elastic property like that of a rubber band is present in alveoli due to the presence of a specific protein fiber, and that is elastic fiber. Okay, now let's get into the hypothesis. See, there are two types of proteins circulating in your blood. Number one, protein that breaks down elastic fiber or elastase, and protein that prevents the breakdown of this elastic fiber or anti-elastase. Fine? Elastase, anti-elastase. Since elastase is breaking down elastic protein, it is protease. Since anti-elastase is preventing the breakdown of this protein, it is anti-protease. So you have elastase and anti-elastase, which are nothing but protease and anti-protease. Physiologically, that is normally the amount of elastase and the amount of anti-elastase, or the amount of protease and the amount of anti-protease circulating in your blood is the same. That is why there is no excess destruction of elastic fiber. Elastase is something that is produced by neutrophil. And talking about anti-elastase or anti-protease, the most famous anti-protease present in your body, in your blood circulation, is produced by your liver, and it is alpha-1 antitrypsin. So I mentioned various etiological factors here, right? What do? They either increase the amount of elastase or decrease the amount of anti-elastase, or do both, that is increase elastase and decrease anti-elastase at the same time. As a result, elastase becomes more than anti-elastase, there is more destruction of elastic tissue, and there is emphysema. Got it? No? Okay. Hear me out. This simple, very simple. There is elastase that breaks down elastic tissue. There is anti-elastase that prevents the breakdown of elastic tissue. When elastase is more than anti-elastase, there is excess breakdown of elastic tissue. When there is excess breakdown of elastic tissue, the alveoli, it loses its ability to recoil, and the person gets emphysema. Boss, that much. See, elastase, anti-elastase normally in your body equal. In emphysema, elastase more or anti-elastase less, or there is elastase more and anti-elastase less. Overall, elastase more than anti-elastase. As a result, there is excess breakdown of elastic fibers. The alveoli loses its ability to recoil, and the person gets emphysema. Good. All right. So this is your basic pathology, pathogenesis. Now, specific pathogenesis for two etiological factors. The most common etiology, that is smoking, and the specific etiology, that is alpha-1 antitrypsin deficiency. First, smoking. See, smoking does both. It increases elastase. It also decreases anti-elastase, right? It decreases anti-elastase, it also increases elastase. How? So smoking, it applies stress in acinus, resulting in inflammation, and due to inflammation there is recruitment of inflammatory cells, which also includes obviously the neutrophil. And it is said that smoking results in 10 times increase in the number of neutrophil. And if I remember correctly, previously I said that it is the neutrophil that produces elastase. That means 10 times the number of neutrophil, 10 times the amount of elastase. So there is immense increase in elastase. Second, the smoke produced contains oxidant, which inhibits the activity of alpha-1 antitrypsin. So there is reduced activity of anti-elastase. So there was increase in elastase, now there is also reduced activity of anti-elastase, overall leading to increased fibrolytic destruction of elastic fibers, resulting in emphysema. Next, genetic reason or alpha-1 antitrypsin deficiency. See, it's your liver that produces alpha-1 antitrypsin. What is it? It is an anti-protease. So you can also call it alpha-1 protease inhibitor, because it is acting against protease now. It is inhibiting the activity of protease. So it is alpha-1 and protease inhibitor, right? So which gene would be responsible for the production or the synthesis of this protein, or the production of protease inhibitor protein? Obviously protease inhibitor gene. Protease inhibitor gene. Now the question arises, in which chromosome is the protease inhibitor gene present? It is present in chromosome number 14, 1, 4, 14. So this is chromosome number 14 with protease inhibitor gene. More specifically, SERPINA1. Simple. SER simply stands for serine, P for protease, and IN for inhibitor. So serine protease inhibitor type A1. That's not important. What is important for you to know is that the gene that is responsible for the production of alpha-1 antitrypsin or alpha-1 protease inhibitor, it's present in chromosome number 14. And this gene has two allelic form. There's the M form and the Z form. The M is normal. If you combine two N together, let's say normal, N, two N together, you get an M. So it's the normal allele. Then if you spell diseased or say diseased with a Z, diseased, right? So Z is the diseased allele. So this allele, they are obviously present in pair. Let's look at the various genotypes found by the allelic pairs. So there's protease inhibitor MM. This is the normal genotype which produces a normal alpha-1 antitrypsin. Then there is protease inhibitor MZ. So it is partially normal and partially diseased or a carrier genotype. Then there is protease inhibitor ZZ. That is, this is a diseased genotype. See, another question that arises is that in emphysema, which two organs are affected? Okay, the lung is affected because you have emphysema. It is a lung pathology. But if the emphysema is due to alpha-1 antitrypsin deficiency, then your liver is also affected. How? See, when you have diseased allelic pair, right? Protease inhibitor ZZ, which is diseased genotype. What happens? What happens if there is diseased genotype? There is production of misfolded alpha-1 antitrypsin in the liver. And the accumulation of misfolded alpha-1 antitrypsin in the liver causes liver cirrhosis. Alright, now the types of emphysema: centri-acinar, pan-acinar, distal acinar, irregular. Very easy, hear me out. See, this is your respiratory bronchial, this is your alveolar duct and sac. Alright, respiratory bronchial, alveolar duct and sac. 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 In centri-acinar, which part is affected? Central part is affected. Which is the central part? The respiratory bronchial is the central part. So it's the respiratory bronchial which is affected. The alveolar duct and sac are spared. Pan-acinar. Pan means what? Complete. That means the complete acinus is affected. Respiratory bronchial as well as alveolar duct and sac are affected. Distal acinar. That means the distal part of the acinus is affected. That is the alveolar duct and sac are affected. Respiratory bronchial is spared. Irregular emphysema. That is, there is irregular involvement. Somewhere respiratory duct and sac are affected, somewhere alveolar duct and sac are involved, somewhere respiratory bronchial is involved. Which is most common clinically? That is, a patient approaches you with signs and symptoms of emphysema. Then which type of emphysema is most commonly seen? It is the centri-acinar emphysema. So most common clinically is centri-acinar type. Which is most common histologically? That is, let's say a person has died and you do autopsy of this person, and if the dead body seems to have emphysema in its lung, then the type of emphysema seen histologically upon autopsy is irregular emphysema. Centri-acinar emphysema is caused due to smoking. Smoke goes up, so the most common lobe affected is upper lobe. Pan-acinar is due to alpha-1 antitrypsin deficiency. Since upper lobe is already affected, it's the lower lobe that gets affected. Imagine the distal part of the acinus, the alveolar duct and the alveolar sac, as a balloon filled with air. Now let's say this balloon bursts, pops spontaneously. As a result, all the air from inside the balloon leaks out. As a result, the chest gets filled with air. which is pneumothorax. Since there is spontaneously bursting of the balloon, it is spontaneous pneumothorax. So spontaneous pneumothorax is seen where there is distal balloon. Distal balloon means the distal part of the acinus is involved, that is distal acinar or paraseptal emphysema. Alright, one last revision. So centri acinar, the central part of the respiratory bronchiole is affected, the duct and sac are spared. Pan acinar, the complete acinar, that is respiratory bronchiole, alveolar duct and sac are affected. Distal acinar, that is the distal part of the acinus or the alveolar duct and sac are affected, the respiratory bronchiole is spared. Irregular, there is irregular involvement. Somewhere it's the respiratory bronchiole that is affected, somewhere it is the alveolar duct and sac that is affected. Most common clinically, centri acinar. Most common histologically, irregular. Smoking causes centri acinar, affecting the upper lobe. Alpha-1 antitrypsin deficiency causes pan-acinar, affecting the lower lobe. Spontaneous pneumothorax is seen associated with distal acinar. Alright, so in centri acinar, there is partial involvement and partial normal. So grossly as well, you can see partial involvement, and areas that is normal, Pan-acinar, there is complete involvement. So grossly as well, you will see complete involvement. In distal acinar or paraseptal, it's the septal region that is affected. Okay, I hope you can determine the type on the basis of these gross features. So there is partial involvement here, right? But then these areas, they are normal. These areas, they are normal. These areas, they are normal. That means there is partial involvement, centri acinar. The complete parenchyma is emphysematous. Complete parenchyma. So it is pan-acinar. It is only the paraseptal region, the septal region that is affected. So it is paraseptal emphysema. What is this? This is also emphysema, but it is associated with the formation of bulla and blebs, so-called bullous emphysema. Microscopy. At the beginning of emphysema, during the definition of emphysema, I asked you to remember 3 words, right? These 3 words are important in microscopy. See, what did I say? Emphysema, there is damage to acini, which is associated with 3 stuff. Number 1, destruction. Due to destruction, you can see floating septa. So you have alveoli, in between alveoli there are septa, and these septa, they break down and then float. So floating septa due to destruction. Number 2, dilation. Due to dilation, the alveoli, they become larger in size. Number 3, fusion. Due to fusion, there is increased pore of Kohn. Clinical feature. See, there was destruction of elastic tissue. As a result, the alveoli lost its ability to recoil. So the patient is able to take in oxygen but unable to flush out carbon dioxide. So what happens? 2 things happen. Number 1, the patient gets a barrel-shaped chest. Why? Enough air is being taken in, enough air is being inhaled, the lung is filled with air, but the person is not being able to exhale air out. Enough is being inhaled, so the lung, it grows larger in size due to overinflation. So the person has overinflated large lung. The diaphragm gets flattened as it gets pushed down. So overinflated large lung with flattened diaphragm. Second, pink puffer. See, normally during chronic obstructive pulmonary disease, due to obstruction, what would you expect? Due to obstruction, reduced oxygen in blood, leading to hypoxia, eventually leading to cyanosis. But in early emphysema, as I said earlier, the person is able to take in oxygen easily, but not being able to flush out carbon dioxide. That means the amount of oxygen in the blood is okay. The oxygen is well saturated with oxygen. The blood is well saturated with oxygen. So pink. Puffer, why? Again, the person is having dyspnea. Unable to breathe properly. Unable to flush out carbon dioxide. Dyspnea. So as compensation, he or she starts pursed lip breathing. That is inhalation with closed lip and exhalation with pursing of the lips. Like this. This is pursed lip breathing. And that's it for emphysema. One last revision. So first, definition. So there is permanent damage of acini. Three things: destruction, dilation, and fusion. Etiology. The most common cause for chronic obstructive pulmonary disease is smoking. The specific cause for emphysema is alpha-1 antitrypsin deficiency. Other causes are environmental pollution, genetics, familial reason, and occupation, like pneumoconiosis. Pathogenesis. So it is based on protease antiprotease hypothesis, according to which normally elastase equals to anti-elastase in circulating blood. But if due to any etiological factor elastase becomes more than anti-elastase, there is destruction of elastic fibers and the alveoli loses its ability to recoil, leading to emphysema. And then what does smoking do? Smoking, it increases elastase as well as decreases the activity of alpha-1 antitrypsin. It increases elastase by 10 times, increasing the number of neutrophil. It decreases anti-elastase because the oxidant present in the smoke of the cigarette, it inhibits the activity of alpha-1 antitrypsin. What about genetics? So chromosome number 14 contains the gene responsible for the synthesis of alpha-1 antitrypsin or alpha-1 protease inhibitor. Let's say there is mutation in its gene, like protease inhibitor ZZ, which is disease genotype. There is formation of misfolded alpha-1 antitrypsin, which gets accumulated in the liver, leading to liver cirrhosis, as well as emphysema in lung, liver cirrhosis in liver. Then types, there are 4 types. Centri acinar affects the respiratory bronchiole. Pan acinar affects both respiratory bronchiole and alveolar duct and sac. Distal acinar affects alveolar duct and sac. Irregular has irregular involvement. Most common clinically is centri acinar. Most common histologically is irregular. Smoking causes centri acinar, affects the upper lobe. Alpha-1 antitrypsin deficiency causes pan acinar, affects the lower lobe. Then spontaneous pneumothorax is associated with distal acinar. Grossly partial involvement and partial normal is seen in centri acinar. Complete involvement is seen in pan acinar. Septal involvement is seen in paraseptal distal acinar. Presence of blebs and bullae are seen in bullous emphysema. Microscopically, 3 terms: destruction leading to floating septa, dilation leading to large acinus, large alveoli, and fusion leading to increased pores of Kohn. Clinically, 2 things: barrel shaped chest and pink puffer. And we're done with emphysema. Up next, we have chronic bronchitis. So, chronic bronchitis. First, or number 1, definition. Chronic bronchitis has been defined clinically. That is, if a patient comes to you with chronic bronchitis, what type of history is he presented with? This is what you can see in patient. This is the history that you can see in patient. So there is persistent productive coughing. That is, there is cough with mucus. Productive means there is cough with mucus for at least 3 consecutive months, for at least 2 consecutive years. This means, let's say this is 2024 and the patient has had coughing for 3 consecutive months, maybe January, February, and then March. 3 consecutive months. And then again in 2025, he had coughing for another 3 consecutive months, maybe February, March, and then April. So there is coughing, again productive coughing, for 3 consecutive months, in 2 consecutive years, and this is at least. So there is persistent productive coughing for at least 3 consecutive months in at least 2 consecutive years. However, whenever a patient presents to you with a history of coughing, chronic bronchitis does not come in the top hierarchy of your diagnosis. What comes? Something like tuberculosis comes, not chronic bronchitis. That is why you can call a patient, you can tell that a patient has chronic bronchitis only when all other possible suspicions have been ruled out. That is, the person does not have TB, that is, the person does not have any other pathologies that is accompanied with productive coughing. Then finally, if the patient is presented with 3 consecutive months of coughing for 2 consecutive years at least, then that is chronic bronchitis. Alright, one last time. What is chronic bronchitis? Clinically defined, chronic bronchitis is when a person has a persistent productive coughing for at least 3 consecutive months for at least 2 consecutive years when all other possible suspicions have been ruled out. Alright. Number 2, etiology. Again, and I'm repeating again, the most common cause of chronic obstructive pulmonary disease, be it emphysema or chronic bronchitis, is smoking. Other causes are environmental pollution, occupation, genetics, and infection, which is common for both emphysema and chronic bronchitis. Exacerbation. See, a person has chronic bronchitis, but then the condition worsens. This worsening of the condition is called exacerbation. Now, exacerbation can take place 2 ways. Number 1, via infection. And the infection that is most commonly exacerbate chronic bronchitis is Haemophilus influenzae. Second most common is Moraxella. Another exacerbating factor is CFTR dysfunction. When there is dysfunction of CFTR, which is due to smoking, there is mucus production because there is productive coughing, but then the mucus is dehydrated, so the condition worsens even more. Alright, then pathogenesis. See, I mentioned the various etiological factor, right? Where do these etiological factor go and act? It is a bronchitis. There is inflammation of trachea and bronchi. So these etiological factor go and put stress on the wall of the trachea and bronchi. So you have etiological stress on trachea and bronchi, resulting in hyperplasia and hypertrophy of the 2 glands present in the wall of the trachea and bronchi. What are those 2 glands? The goblet cells, the unicellular glands, the goblet cells present in the lining epithelium, right? The ciliated pseudostratified columnar epithelium from the general anatomy, and the submucosal glands present in submucosa. There is hypertrophy and hyperplasia of these glands. As a result, 2 things happen. Due to hyperplasia and hypertrophy of submucosal glands, 2 things happen. Number 1, there is increased mucus production. Obviously, submucosal glands, they contain mucus secreting glands, and they produce more and more mucus, so there is increased production of mucus. Now, what you need to know is that mucus, right? Mucus, it acts as a fertile soil for infection. So since there is lots and lots of production of mucus lining your trachea, bronchi, bronchioles, and even till alveoli, there is infection that take place in respiratory tract, which further exacerbate the condition, that is further worsen the condition. So most commonly, what infection? Haemophilus influenzae. Second most common, Moraxella. Infection can also lead to secondary ciliary dyskinesis. Alright, what if this mucus production is associated with CFTR dysfunction, which is seen due to smoking? Then there is production of mucus, but the mucus is dehydrated. So there is further worsening of the condition, also known as exacerbation. Second thing that happens is there is increase in Reed's index. The normal Reed's index is 0.4. This brings the question, what is Reed's index? So this is the Reed's index. See, this is the wall of your bronchus. So there is mucosa. The mucosa contains the epithelial mucosa, lamina propria, muscular layer, and submucosa with the submucosal gland. Reed's index is nothing but A upon B. Now what you need to know, what is A and what is B. So A, as you can see right here, is the thickness of the submucosa. No, it's the thickness of the submucosal glands. So this whole thing is submucosa, right? But then this much is the thickness of the submucosal gland. So A tells you the thickness of the submucosal glands. All right. What is B? B is the thickness of mucosa plus submucosa, the whole thing. Mucosa plus submucosa. Now see, normally the thickness of submucosal gland by thickness of mucosa plus submucosa is 0.4. When there is chronic bronchitis, there is hyperplasia and hypertrophy of the submucosal gland. So there is increase in the thickness of the submucosal gland, but then the overall thickness remains almost the same, right? What I mean is there is increase in numerator, but then the denominator remains almost the same. That means there is increase in Reid's index. All right, one more time. Reid's index is nothing but the ratio of what to what? The thickness of submucosal glands to the complete thickness of mucosa plus submucosa. When there is chronic bronchitis, there is hyperplasia and hypertrophy of submucosal gland. So there is increase in the thickness of submucosal gland, while the overall thickness remains almost the same. That is, the denominator remains the same, but the numerator, it increases. So overall, the Reid's index increases. All right. Gross. So grossly, since there is lots and lots of production of mucus, the small airways, it gets blocked or filled with mucus. Sometimes due to increased production of mucus, lots of fibrosis and inflammation, the lumen gets completely covered up or completely obliterated. The lumen of the bronchiole, this is the lumen of the bronchiole, gets completely obliterated, and this is called bronchiolitis obliterans. Bronchio, because bronchiole is affected. Itis, because there is inflammation. Obliterans, because there is complete covering of the lumen or the obliteration of the lumen. Microscopy, the same thing. Hyperplasia and hypertrophy of goblet cells and submucosal glands. Clinical features. See, I said earlier that the alveoli is lined with lots and lots of mucus. That means there is increase in the thickness of respiratory membrane. That means there is decrease in diffusion of gases. Since there is decrease in diffusion of gases, there is decreased oxygen saturation of blood. Since there is decreased oxygen saturation of blood, you have hypoxia. Now, hypoxia can lead to two things. Number one, hypoxemia, reduced oxygen in blood, leading to cyanosis. So the patient is blue. Or see, whenever there is hypoxia, vasodilation of systemic blood vessels take place to supply as much oxygen as possible to the body, but vasoconstriction of pulmonary blood vessels take place. Due to pulmonary vasoconstriction, there is increased total peripheral resistance of pulmonary blood vessel, right? Pulmonary vasoconstriction leading to increased peripheral resistance, vasoconstriction leading to pulmonary hypertension. Pulmonary hypertension, that means the right heart has to work more, it has to press much more harder, it has to work harder, and it ultimately fails to work, leading to right heart failure. Since the right heart has to work harder, the right ventricle has to work harder, there is right ventricular hypertrophy called cor pulmonale. Since the right heart is unable to pump the blood, there is accumulation of blood leading to peripheral edema, leading to bloating, so bloater. That is why chronic bronchitis patients are often seen as blue bloaters, and emphysema patients are seen as pink puffers. Alright, see, here's the thing. Emphysema and chronic bronchitis, both of them are what? Chronic obstructive pulmonary disease. Both of them are strongly associated with what? Smoking. So there are chances that the clinical features of one might overlap with the other. It is just that when there is predominant emphysema, the clinical features of emphysema are more seen, when there is predominant chronic bronchitis, the clinical features of chronic bronchitis are more seen. And in case of emphysema, the typical feature of the patient is pink puffer. And in case of chronic bronchitis, the typical feature of the patient is blue bloater. I'm really sorry for my voice because it's like done for due to all the coughing that I had been going. I didn't have chronic bronchitis again, it was just common cold. Alright, so chronic bronchitis, one last revision. Number one, definition. It is defined clinically where there is persistent productive coughing for at least 3 consecutive months, for at least 2 consecutive years, when all other suspicions have been ruled out. Number 2, etiology. For chronic obstructive pulmonary disease, the most common etiology is smoking. Other are environmental pollution, occupation related like pneumoconiosis, infection, and genetics. Then pathogenesis. In pathogenesis, so there is the etiological stress like smoke from smoking, which puts stress on the wall of the trachea and bronchi. As a result, hyperplasia and hypertrophy of 2 glands take place, the goblet cells and the submucosal glands. As a result, there is increased production of mucus. Mucus is a fertile soil for infection. So infection takes place, exacerbation takes place. Infection by Haemophilus influenzae and Moraxella. Sometimes due to smoking, CFTR dysfunction can lead to production of mucus that is dehydrated. This can exacerbate or worsen the condition as well. I'm so sorry for my voice. What is happening? Okay, worsen the condition even more as well. Second thing that happens is that there is increase in Reed's index. Normally, Reed's index is 0.4. Reed's index is defined as the ratio of the thickness of submucosal gland to the thickness of mucosa plus submucosa. Since there is hyperplasia and hypertrophy of submucosal gland, there is increase in the thickness of submucosal gland without much increase in the thickness of mucosa plus submucosa. So there is overall increase in Reed's index. Okay, as for gross, you can see that the small tubes, the small airways, they are filled with mucus. Sometimes they are so much filled with mucus, like your bronchiole is so much filled with mucus and fibrosis that it is completely, the lumen of the bronchiole is completely obliterated, which we refer to as bronchiolitis obliterans. Grossly, if you see, this is what you see. Microscopy, if you see, there is increase in Reed's index due to hypertrophy and hyperplasia of submucosa gland. There is also hypertrophy and hyperplasia of goblet cells. And clinical features. Since there is increased production of mucus, the mucus lines the alveoli, increasing the thickness of respiratory membrane, decreasing diffusion of gases, and leading to hypoxia. And now hypoxia, when worsens, can lead to cyanosis. As a result, the patient appear blue. At the same time, due to hypoxia, there is pulmonary vasoconstriction, leading to pulmonary hypertension, leading to right heart failure, leading to cor pulmonale, leading to peripheral edema. So the patient appears as a bloater. Overall, blue bloater. So, yeah, chronic bronchitis done. So we are finally done with chronic obstructive pulmonary disease. The next disease in line under obstructive pulmonary disease is asthma. Asthma, number 1, definition. There is tracheobronchial spasm characterized by paroxysmal blah 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 blah. Hear me out. So, the part of the respiratory tract that is affected in asthma is trachea and bronchi. So, mostly it is the trachea and bronchi that is affected. What happens? Number 1, there is bronchoconstriction. And number 2, there is increased secretion of mucus. So due to bronchoconstriction, due to increased secretion of mucus, the narrowing of the lumen takes place. Due to narrowing of the lumen, what happens? There is difficulty breathing, which is dyspnea. There is a peculiar sound that is heard on auscultating the chest, which is wheezing, an added sound. And since there is mucus, you want to cough it out, right? So there is coughing. So what you get is recurrent or paroxysmal attacks of DCW, dyspnea, coughing and wheezing. Paroxysmal means, so there is period of normal, everything is normal, and then there is asthma attack. Then period of normal, then there is asthma attack. That means there are recurrent attacks of asthma. So what is there? There is tracheobronchial spasm characterized by paroxysmal attack of DCW or dyspnea, coughing and wheezing that either heals spontaneously on its own or with therapy. Like you can take an asthma inhaler when you have asthma attack. Etiology. So this is based on the type of asthma. You have atopic asthma and non-atopic asthma. Atopic asthma is due to allergen. Non-atopic asthma is not due to allergen. It is due to something else like respiratory infection or certain drugs or occupation or due to stress or cold air or maybe exercise. Pathogenesis. So if we are talking about atopic asthma, the pathogenesis is the same as type 1 hypersensitivity reaction. So go through your book, look at type 1 hypersensitivity reaction, copy paste that in asthma. Alright. Types. You have two types of asthma, atopic and non-atopic. Atopic is due to allergen. Non-atopic is not due to allergen. It is due to something else like a respiratory infection, drug, occupation, stress, cold air, exercise. Atopic asthma, it begins in children and it is IgE mediated, obviously, because it shows type 1 hypersensitivity reaction. And non-atopic asthma, it is usually seen in adults and it is not IgE mediated because it does not show type 1 hypersensitivity reaction. Next, gross. So let's say a patient who had asthma unfortunately went through an episode of status asthmaticus. Status asthmaticus is when you have asthma attacks, but for a long period of time. So the patient dies. Upon carrying out autopsy, these are the gross features that are seen in the lung. Number 1, mucus plug. Obviously, because there is high secretion of mucus, the lumen gets plugged with mucus. Overinflation of lung, and there are certain areas of atelectasis. Microscopy. Now, microscopy is really important from pathology point of view, and there are two microscopies that you need to know. Number 1, the microscopy of the sputum that gets coughed out. And number 2, the microscopy of the lung parenchyma itself. Sorry, not the lung parenchyma, the microscopy of the trachea or the bronchi itself. First, the microscopy of the sputum. So you have the sputum sample. The sputum sample is fixed on a slide using Sacco-Mano fixative. Upon looking at it under a microscope, you can see 3 C's at the rate 3 C's. What are the 3 C's? Number 1, the Kurzman spiral. Number 2, the charcot-laden crystal. Number 3, the Crayola body. The Kurzman spiral is nothing but spirally coiled mucus that gets coughed out. Charcot-laden crystal is nothing but galactin 10. What is galactin 10? Galactin 10, see, during asthma, especially allergic asthma, there is increased number of eosinophil, because during allergy, what comes? Eosinophil comes. Now, derived from eosinophil is galactin 10. And galactin 10 forms a crystal-like structure, which is charcot-laden crystal. Next is Crayola body. When you cough out, along with sputum, what comes out are the epithelial lining of trachea and bronchi. This is your Crayola bodies. I hope you can identify them. Alright, so identify which one is which. This is spirally coiled Kurzman spiral, right? The Kurzman spiral. Why is the sputum spirally coiled? It's spirally coiled because it takes the shape of the bronchi. Then you have this charcot-laden crystal. It is made from galactin 10, which is derived from eosinophil. Then you have this Crayola body, which is made up of the coughed out epithelial lining or the epithelial cells. So the Kurzman spiral, the charcot-laden crystal, and the crayola body. Now, the microscopy of the bronchi. See, I said in case of chronic bronchitis that Reed's index, it is nothing but the ratio of the thickness of submucosal gland by the thickness of mucosa plus submucosa. In chronic bronchitis, due to increase in the thickness of submucosal gland, there was increase in Reed's index. But in case of asthma, the Reed's index remains normal. Why? Because there is increase in numerator as well as an increase in denominator. Increase in numerator as well as an increase in denominator. That is increase in thickness of submucosal gland as well as an increase in thickness of mucosa and submucosa. How? So there is increase in the thickness of submucosal gland due to hyperplasia and hypertrophy of submucosal glands. There is increase in the thickness of mucosa due to thickening of the basement membrane of lining epithelium, as well as hypertrophy of the muscular layer of bronchi. So that is how there is increase in thickness of mucosa as well. All right. Clinical features. I said in the definition earlier, there is paroxysmal or recurrent attacks of dyspnea, coughing, and wheezing. So that's it for asthma. Revision. First, definition. There is tracheobronchial spasm which is associated with recurrent or paroxysmal attacks of DCW, that is dyspnea, coughing, and wheezing, which either heals spontaneously or with therapy. Then etiology. So if we are talking about atopic asthma, then it is due to allergen. If we are talking about non-atopic asthma, it is not due to allergen, it is due to something else like respiratory infection, drug, occupation, stress, cold air, exercise. Pathogenesis. If we are talking about atopic asthma, then the pathogenesis is ditto copy of type 1 hypersensitivity reaction. Types: atopic asthma, non-atopic asthma. Atopic is due to allergen, non-atopic is not due to allergen, it is due to something else like respiratory infection, drug, occupation, stress, cold air. Atopic asthma, that is allergic asthma, it begins in children. And since it shows type 1 hypersensitivity reaction, it is IgE associated, IgE mediated. In non-atopic asthma, it is usually seen in adults, and since it does not show type 1 hypersensitivity reaction, it is not IgE mediated. Then gross. So grossly, you can see mucus plugs, you can see inflated lung and areas of atelectasis. Microscopically, if you look at the microscopy of sputum, you can see the 3 C's. They are the Crossman spiral, the charcot-laden crystal, and the crayola body. The Crossman spiral is nothing but spirally coiled mucus that gets coughed out. Charcot-laden crystal is nothing but made up of galactin 10, which is derived from eosinophil. Crayola body is nothing but a mass of epithelial cell that gets coughed out. Then microscopy of the trachea and bronchi shows no change in Reed's index because there is increase in numerator due to increase in thickness of submucosal gland due to hyperplasia and hypertrophy of submucosal gland. At the same time, there is also an increase in denominator due to increase in thickness of mucosa plus submucosa. There is increase in thickness of mucosa due to thickening of the basement membrane as well as the thickening of the muscular layer. As for clinical features, there are paroxysmal or recurrent attacks of dyspnea, coughing, and wheezing. And yeah, we are done with asthma. This is the last disease that you need to know under obstructive pulmonary diseases, and that is bronchiectasis. So like any other disease, first definition. So the name says itself, bronchiectasis. Bronchi refers to bronchi and bronchioles. Ectasis comes from ectasia, which refers to dilation. That is, there is permanent dilatation, ectasia, of bronchi and bronchioles. So which part of the respiratory tract is affected? Bronchi and bronchioles. What is happening to bronchi and bronchioles? Ectasia. There is permanent dilation. Just break the word into two. Bronchi and bronchioles, ectasia, ectasis, ectasia, dilation. So there is permanent dilatation of bronchi and bronchioles. Now, why is it that these tubes, they have dilated? It is because the wall of bronchi and bronchioles have become weak. Why is it that there is weakening of the wall of bronchi and bronchiole? Because there is a destruction of parts or portions of wall of bronchi and bronchiole. Why is it that there is destruction of wall of bronchi and bronchiole? Probably because there is inflammation. So the final thing that you need to remember is that there is damage to wall of bronchi and bronchiole. As a result, there is weakening of wall of bronchi and bronchiole, and as due to which there is permanent dilatation. All right, so there is damage to wall of bronchi and bronchiole, weakening of wall of bronchi and bronchiole, and then permanent dilatation of bronchi and bronchiole. Now the question is, how does this damage occur? What are the causative agents of this damage, or the etiology? So here is the etiology. There are three major etiological factors. Number one, congenital, that is by birth the child might have something called Kartagener's syndrome, which is strongly associated with bronchiectasis. Number two, acquired, later on in life there might be obstruction in the tube or infection that leads to bronchiectasis. How? See, obstruction, it can be due to the formation of tumor within the tube, or maybe formation of tumor or compression from outside. All right, infection is infection. Then immune disorder like rheumatoid arthritis, SLE, inflammatory bowel disease, or lung transplant rejection. Pathogenesis. Now, the way the disease develops depends on the etiological factor. For example, if we are talking about Kartagener syndrome, Kartagener syndrome has its own triad, which consists of number one, bronchiectasis, number two, sinusitis, and number three, situs inversus. What are the three things? Number one, bronchiectasis, number two, sinusitis, and number three, situs inversus. Another important thing about Kartagener syndrome is that in Kartagener syndrome, there is something called a primary ciliary dyskinesia. What does this mean? See, your whole respiratory tract is lined by respiratory epithelium, right? Which is the ciliated pseudostratified columnar epithelium. That means there are these tall columnar cells which have cilia. These cilia, they beat in a rowing motion. If you take out one cilia and look at its composition, you can see that it contains something called the dynein arm. In Kartagener syndrome, there is dynein arm defect, and due to dynein arm defect, the cilia loses its ability to move. That is why dyskinesia, that is there is dysfunction in the kinesis or motility of cilia. Ciliary dyskinesia, cilia dysfunction kinesis. There is dysfunction in the kinesis or motility of cilia. Since it is due to Kartagener syndrome, it is primary ciliary dyskinesia. Alright. There's also male and female infertility. Male infertility cause the flagellum of the sperm, it is non-functional. Female infertility cause, see, the fallopian tube, it is also lined after all by ciliated simple columnar epithelium, and the cilia, it becomes dysfunctional, non-functional. As a result, it is unable to beat and transport ovum. So there is female infertility. Second, so there are many etiological factors as I explained, but the most common etiological factor that leads to bronchiectasis is obstruction and infection. During obstruction, let's say this is your bronchi, there is obstruction due to tumor. What happens? There is continuous production of secretions, but then these secretions, they don't go down. As a result, there is pooling of all these secretions. There is pooling of mucus, pooling of serous fluid, all of them. They continuously exert stress on the wall of the bronchi. As a result, there is inflammation. On the other hand, infection leads to inflammation. Either way, be it obstruction or infection, there is inflammation. due to inflammation, there is damage of the wall, which leads to weakening of wall and permanent dilatation. Gross. What did I say? What is bronchiectasis? It is the permanent dilatation of bronchi and bronchioles. So what do you expect to see in gross? The dilated bronchi and bronchioles. What else? So you can see dilated bronchi and bronchioles. Now, depending on the shape of the dilation, there are various types. You have varicose, you have cylindrically shaped, radish-like fusiform, or saccular. But the important thing that you need to know is that these dilatations, they give off a peculiar appearance, and that is honeycomb appearance, which is most commonly seen in left lower lobe, where LLL, in the left lower lobe. You can see right here, there are many dilated bronchi and bronchioles, and they give off the honeycomb appearance. You can see right here as well, there are these dilated bronchi and bronchioles, that give off the honeycomb appearance microscopically. So I said earlier, there is pooling of secretions. The secretion contains mucus, so there is pooling of mucus. So in lumen, what are you going to see? You are going to see mucus. There is infection leads to pus production, and that's why pus in the lumen. So there is mucopus in the lumen. Second, the mucosal lining or the mucosa, it gets ripped off, or you get slurred mucosa. There is mucosa, then it becomes discontinuous, then mucosa, right? There is discontinuity in mucosa because part of it has been ripped off, slurred off. Then bronchiectasis. What happens in bronchiectasis? Inflammation happens. What happens in inflammation? Inflammatory cells come. So you can see lots and lots of neutrophils throughout the thickness. Lots and lots of neutrophils. You can see right here, there's the slurred mucosa. So what are the three major things? Number one, mucopus in lumen. Number two, slurred mucosa. And number three, inflammatory infiltration. Clinical feature. So a 40 years old male presents with history of 2 years, quite a long history, of productive cough, that is cough with sputum. And the peculiarity of this sputum is that it is extremely foul smelling. So with foul smelling sputum, recurrent fever, given is the bronchial biopsy and X-ray. In bronchial biopsy, you are able to see the slurred of mucosa, and in X-ray, you are able to see a peculiar appearance, that is tram track appearance. So these are the tracks, these are the two tracks of the tram track arranged parallelly. Similarly, the bronchi and bronchioles are also present or visible, arranged parallel to one another. So that is the tram track appearance. So clinically, the patient presents with, most importantly, foul smelling sputum, and upon X-ray, the presence of tram track appearance. In chronic cases, there might be amyloidosis as well. So that's it. One last revision. Bronchiectasis. First, definition. Bronchi referring to bronchi and bronchioles. Ectasis comes from ectasia, which means dilation. So there is permanent dilatation of bronchi and bronchioles. Number two, etiology. So there is congenital etiology like Kartagener syndrome. There is acquired etiology like obstruction and infection. And then there is immune disorders like rheumatoid arthritis, SLE, inflammatory bowel disease, and rejection of lung transplant. Pathogenesis, which is dependent on etiology. If we are talking about Kartagener syndrome, then there is primary ciliary dyskinesia due to dyne-in-arm defect, which leads to pooling of the secretion and inflammation, weakening of the wall, and bronchiectasis. If we are talking about obstruction and infection, again there is pooling of the secretion, there is infection leading to pus production, inflammation, weakening of the wall, and bronchiectasis. Then grossly you can see dilated bronchi and bronchioles, which give off a peculiar appearance called honeycomb appearance, which is most commonly seen in left lower lobe of the lung. Microscopically, three things: mucopus in lumen, slurred of mucosa, and inflammatory infiltrates throughout the thickness. Clinical features: the patient presents with foul smelling sputum. Upon X-ray, you can see tram track appearance, and in case of chronic cases, there might be amyloidosis. And we are done with bronchiectasis, or shall I say, we are done with complete obstructive pulmonary diseases. Next up, we are going to look at pneumoconiosis. The three major types of pneumoconiosis: the cold worker pneumoconiosis, silicosis, and asbestosis. Pneumoconiosis. Pneumoconiosis is a non-neoplastic reaction of lung in response to inhaled dust. What do I mean? See, let's say there's a person who works in a coal mine. As a result, he's continuously exposed to coal. So he inhales that coal. The coal passes through the respiratory tract and reaches the lung. Inside the lung responds to the inhaled coal in the form of non-neoplastic reaction. As a result, lung damage takes place and the lung ability to function reduces or it is completely over. The lung fails. This is pneumoconiosis. In pneumoconiosis, there is non-neoplastic reaction of the lung in response to what? In response to inhaled dust. Where does this dust come from? This dust comes from a person working in a certain setup, like a miner working in a coal mine. He is continuously exposed to coal. In community medicine, you are going to learn pneumoconiosis as an occupation acquired disease. That is because all the pathologies related to lung is being acquired by the person working in a particular setup. As I said earlier, the miner working in coal mine led to him being continuously exposed to coal, leading to pneumoconiosis. So it is acquired from his job as a coal miner. So it is occupation acquired disease. Fine. And I said that pneumoconiosis is caused due to inhalation of dust, right? What are the types of dust? So there are two types of dust. There's organic dust and mineral dust. Organic dust like hay, cotton, and mineral dust, which are inorganic dust like coal, silica, asbestos. Depending on the type of mineral dust, which causes pneumoconiosis are of various types. That is, if pneumoconiosis is caused by coal, we call it coal worker pneumoconiosis. If pneumoconiosis is caused by silica, we call it silicosis. If pneumoconiosis is caused by asbestos, we call it asbestosis. So these are the three major pneumoconiosis caused by mineral dusts that you need to know in detail. All right. At a corner, you can see this, something I have written in bracket, right? What have I written? I have written 1 to 5 micrometer. What does it mean? What could it possibly mean? It is referring to the size of the dust particle. Dust particle 1 to 5 micrometer in diameter. What's the significance? It is the dust particle of size 1 to 5 micrometer in diameter that is most responsible for causing pneumoconiosis. Why this particular value? Why 1 to 5 micrometer? What if the dust size is less than 1 micrometer? Or what if the dust size is greater than 5 micrometer? What then? See, if the dust size is less than 1 micrometer, it will pass through the respiratory tract and then finally reach the alveoli. But then it can return back outside as well. So if the dust particle size is less than 1 micrometer, it can easily enter in, but then it can easily exit out as well. And if it exits out, it is not gonna show any long reaction, so it is not pathogenic. What if the size is greater than 5 micrometer? Then it will get trapped in the respiratory tract. It will get trapped by the cilia and the mucus of the respiratory tract. It will never enter the lung and lung reaction will not take place. All right. Now, the details of the three types of pneumoconiosis. Coal worker pneumoconiosis is caused by exposure to coal. Coal contains carbon. Carbon is an anthracotic pigment. Silicosis is caused by exposure to silica. There are two types of silica, crystalline and amorphous. Crystalline is more pathogenic, namely quartz. What is quartz? Quartz is crystalline SiO2 and it is highly pathogenic. Third is asbestosis, which is caused by exposure to asbestos. All right. Now, how is a person exposed to this? So, exposure to coal is through coal mines. Exposure to silica is through glass industry because glass is made of silica. Exposure to asbestos is through shipyard industry. What is shipyard industry? Shipyard industry deals with number one, manufacture, and number two, repair of ships. And ship parts are majorly made up of asbestos. So the workers working in shipyard industry are continuously exposed to asbestos. All right. So you need to know about asbestos dust in more detail. Asbestos. So asbestos particles, they are present in two major forms. There are many forms, two major forms. The serpentine chrysolite and amphibole or crocodolite. Serpentine chrysolite, it is most commonly used. That is 90% of the use of asbestos taking place is that of which form? The serpentine chrysolite form. Amphibole, on the other hand, is less prevalent. However, it is way more pathogenic. What do I mean by way more pathogenic? See, asbestos, it causes asbestosis, right? Asbestos causes asbestosis, which is a pneumoconiosis. Now, asbestosis has the tendency to develop into mesothelioma. Mesothelioma. What is mesothelioma? Mesothelioma is the malignant tumor of lung pleura. So out of these two different forms of asbestos, amphibole has a higher tendency to develop, amphibole has the higher tendency to cause mesothelioma. All right. What's the reason behind it? So the reason behind it is the aerodynamics of the particle structure. This is what I mean. So chrysolite is snake-like in structure, snake-like, whirly, coiled. It is whirled, coiled, wavy, so-called serpentine chrysolite. Since it is snake-like, wavy, it is easily trapped in the mucociliary, in the mucus and cilia of the respiratory tract. It is easily trapped, right? So it does not enter the lung and lung reaction does not take place. Amphibole, on the other hand, or crocodolite on the other hand, it is needle-like and long, So it is easily able to evade or pass through the mucociliary, the mucus and cilia. It is easily able to evade through it and enter the lung, causing asbestosis and then worsening into mesothelioma. All right. Be it silicosis or co-worker pneumoconiosis or asbestosis, the good thing for you is that they all have similar pathogenesis. There is a common pathway in their pathogenesis, and this is how it takes place. First, you have the dust particle itself, which is either coal in causing co-worker pneumoconiosis, silica causing silicosis, or asbestos causing asbestosis. This dust, when the person is exposed to this dust, it gets inhaled in. It passes through the respiratory tract and then enters the alveoli. In your lungs, inside and outside and in between alveoli, there are macrophages. The macrophages found in your lung are called dust cells. So this dust that gets inhaled in are eaten up by the dust cells. So what you get is dust engulfed dust cells or dust laden macrophages. Alright, so there was dust, you inhaled that dust, the dust reached the alveoli of your lung, it got eaten up by the dust cell or the macrophage. Now you have the dust laden macrophage. Now this triggers the macrophage to produce cytokines, in response to which inflammation takes place, which is followed by healing by fibrosis, and then finally there is scarring or scar formation. This is the mul mantra of general pathology. I hope you know this much. There is vascular injury. Vascular injury is followed by inflammation. Inflammation is followed by healing by fibrosis, and then fibrosis leads to scar formation or scarring, right? You know about vascular injury, you know about inflammation, you know about fibrosis, you know about scarring from general path. So the same thing happens for co-worker pneumoconiosis. The coal enters your alveoli, inflammation, fibrosis, scarring. Silicosis, silica enters the alveoli, inflammation, fibrosis, scarring. Asbestosis, asbestos enters the alveoli, inflammation, fibrosis, scarring. However, in asbestosis, this is not there. I'll explain that soon enough. This is not there in asbestosis. Wait, I'll explain. Starting off with co-worker pneumoconiosis. Okay, so co-worker pneumoconiosis is caused by coal. which contains carbon, which is an anthracotic pigment. Depending on the severity of the condition, the severity of the pathology, cold worker pneumoconiosis is of three types. You have anthracosis, simple cold worker pneumoconiosis, and complicated cold worker pneumoconiosis. Let's say there's a person who works in a coal mine. So he's being continuously exposed to carbon or coal. So during initial exposure or the beginning stage, the person gets cold worker pneumoconiosis without any symptom, asymptomatic. This is called anthracosis. Again, so the beginning stage is anthracosis. Now, anthracosis worsens into simple cold worker pneumoconiosis upon 4 to 5 years of exposure, and simple cold worker pneumoconiosis worsens into complicated cold worker pneumoconiosis upon many years of exposure. So initially, the beginning stage is anthracosis, where there is no symptoms, it is asymptomatic. Then there's simple cold worker pneumoconiosis upon 4 to 5 years of exposure, where there is little to no pulmonary dysfunction. And finally, there is complicated cold worker pneumoconiosis upon many years of exposure. Here, the lung function is compromised. Why? Because there is massive fibrosis. Again, go back, common pathogenesis. At the end of the day, what is taking place? Scarring is taking place due to fibrosis. So there is fibrosis and scar formation in the lung, and the lung loses its ability to function. The lung function gets compromised. Since there is massive fibrosis, it is also called complicated cold worker pneumoconiosis, is also called progressive massive fibrosis. Okay, now cross. In anthracosis, the lung contains these black pigmented dots. In simple cold worker pneumoconiosis, the lung contains black nodules and macules. Macules, they are present in the form of a patch, flat patches, and nodules, they are raised lesions. So macules are flat patchy lesions, nodules, they are raised lesions. Complicated cold worker pneumoconiosis, there is complete scarring of the lung. There are black scars. These macules and nodules, they are few millimeter in size. On the other hand, the black scars, they are larger, they are centimeter in size. Microscopy. See, relate with pathogenesis. So first, the coal entered inside, it reached the alveoli. Inside the alveoli, the coal gets eaten up by the macrophage. So you get coal-laden macrophages. Alright. Now the deposition of coal takes place in the interstitial space as well. So coal in interstitial space. In a response to all this, inflammation takes place, which is followed by healing by fibrosis and then scar formation. So there is fibrosis as well. So as the condition worsens, the microscopical stages gets added up as well. As simple as that. So in anthracosis, in all these black dots, these black pigmented dots, you are gonna find coal-laden macrophages. In simple cold worker pneumoconiosis, in all these black macules and nodules, you are going to find coal-laden macrophage plus coal in interstitial space. In complicated cold worker pneumoconiosis, in these black scars, you are going to find coal-laden macrophage plus coal in interstitial space plus fibrosis. This is the microscopy of complicated cold worker pneumoconiosis. All the black things that you are looking at is coal-laden macrophages, and the fibers are a result of fibrosis, healing by fibrosis. Okay. Next up, silicosis. Silicosis is caused by exposure to silica, which is present in crystalline and amorphous form. Which is more pathogenic? Crystalline form is more pathogenic. For example, quartz, which is crystalline SiO2. Alright. Grossly, what is present are the silicotic nodules. So there are silicotic nodules all over the lung. There are silicotic nodules. Sometimes these silicotic nodules might worsen, causing cavitation in the lung. There will also be involvement of lymph nodes. Which lymph nodes? The hilar lymph nodes and the mediastinal lymph nodes. The mediastinal lymph nodes. So the lymph nodes, fibrosis occurs, right? And to this fibrosis, there is deposition of calcium, leading to dystrophic calcification. This dystrophic calcification of hilar and mediastinal lymph nodes is appreciable under X-ray in the form of egg cell calcification. So you can look at this bunch of egg cell-like structure. Egg cell-like structure, right? This is due to egg cell. This is called egg cell calcification, and this is due to dystrophic calcification of hilar and mediastinal lymph nodes. Okay, microscopy. So this is the pathogenesis showing microscopy. This is what happens. Again, the same thing. Silica enters the alveoli. There is exposure to silica. Silica passes through the respiratory tract, eventually reaches the alveoli. Inside the alveoli, the silica gets eaten up by macrophages, which initiates inflammation, which is followed by fibrosis. So you can see these fibrosis taking place, and then there are these fibroblast cells responsible for the synthesis and secretion of fibers, and eventually there is formation of silicotic nodule. So if I take a microscopic section of this silicotic nodule, take a thin microscopic section of this silicotic nodule, this is what I'm going to see. I'm going to see fibrosis in concentric fashion. Fibrosis in concentric fashion. Since fibrosis is taking place, there are going to be fibroblast cells as well. And since there is inflammation, there are going to be inflammatory cells as well, which are your lymphocytes. And most importantly, there are going to be deposits of silica. And these silica are eaten up by macrophages. So silica-laden macrophages. Okay. So concentric arrangement of fibers with fibroblast and inflammatory cells, namely lymphocytes, along with deposits of silica and silica engulfed by macrophages. Done. Asbestosis. So asbestosis is caused by asbestos. Asbestos is present predominantly in two forms. They are the serpentine chrysolite and amphibole crocodylite. The serpentine chrysolite, it is used in 90% of the cases. Amphibole crocodylite is less prevalent. However, it is way more pathogenic. That is, asbestos that can cause that has the higher tendency to cause mesothelioma is amphibole crocodylite. The reason being the aerodynamic of their particle structure. The serpentine chrysolite is wavy, so it is easily trapped in the mucocilia of your respiratory tract. On the other hand, the amphibole crocodylite, it is needle-like, thin, elongated, so you can easily pass through the mucocilia of your respiratory tract and then enter your lung and deposit inside the lung, causing asbestosis. Gross. Asbestos, it loves pleura. So it is going to harm your pleura. So there is pleural thickening plus subpleural fibrosis. You might have noticed something. The fibrosis has taken place at the base of the lung. And the fact is that in cold worker pneumoconiosis, in silicosis, most of the times in pneumoconiosis, it's the upper lobe of the lung which is affected. Upper lobe or the upper part of the lower lobe. At the end of the day, it is the upper part of the lung that is affected. However, in asbestosis, it's the base of the lung that is affected. You can see pleural plaque in the gross as well. Okay. Microscopy. So the same thing, the asbestos fiber gets inhaled in, it passes through the respiratory tract, then it reaches the alveoli. However, now, like in cold worker pneumoconiosis, the coal got engulfed by alveolar macrophage. In silicosis, the silica got engulfed by alveolar macrophage. But in case of asbestosis, the asbestos fiber is not engulfed by alveolar macrophage. Instead, what happens is that around these asbestos fibers, there is enwrapment of ferritin, which is produced by the macrophage. The ferritin enwraps around and then forms the asbestos body. It forms asbestos body. It forms asbestos body. So if you take a section, microscopic section of asbestotic nodule, you are going to find concentric arrangement of concentric fibrosis along with fiber secreting fibroblast cells and inflammatory lymphocyte cells, along with not asbestos laden macrophage but asbestos bodies. What are asbestos bodies? Asbestos bodies, number one, they are dumbbell shaped. You can see right here, it is dumbbell shaped. Number two, it is made up of asbestos fiber which is enwrapped by ferritin. Ferritin produced from the macrophage itself. It is enwrapped by ferritin. Since it contains ferritin or iron, it is one of the ferruginous bodies. So it is dumbbell shaped ferruginous body which contains asbestos fibers covered by ferritin produced from macrophage. You can see the asbestos body right here. And with that, we are done with pneumoconiosis. One last revision. All right, so pneumoconiosis. Pneumoconiosis definition: it is non-neoplastic reaction of lung in response to inhaled dust, which can be organic dust like hay and cotton or mineral dust like coal, silica and asbestos. It is an occupation-acquired disease. The size of the dust particle that is highly pathogenic is 1 micrometer to 5 micrometer. Less than 1 micrometer, it is too small, so it can enter in and come out. More than 5 micrometer, it is too large, so it will get trapped in the respiratory tract. 3 types of pneumoconiosis: coal worker pneumoconiosis, silicosis and asbestosis. Coal worker pneumoconiosis caused by coal which contains carbon, which is anthracotic pigment. Silicosis caused by silica, the crystalline form, namely quartz. And asbestosis by asbestos, where amphibole is more pathogenic than serpentine chrysolite due to the aerodynamic of the particle structure. Then, as for coal worker pneumoconiosis, there are 3: anthracosis, simple coal worker pneumoconiosis and complicated coal worker pneumoconiosis. Anthracosis is at beginning stage, it is asymptomatic and there is presence of black pigmented dots. Simple coal worker pneumoconiosis is often 4 to 5 years of exposure where there is little to no pulmonary dysfunction and there is presence of black macules or black nodules. In complicated coal worker pneumoconiosis, there is many years of exposure, so there is lung function compromisation. Since there is immense fibrosis, it is also called progressive massive fibrosis, and there are presence of centimeter long black scars. Microscopically, you can see coal-laden macrophage, coal in interstitial space and fibrosis. In silicosis, grossly, you can see silicotic nodules, cavitation and egg cell calcification is seen under X-ray. Microscopically, there is concentric arrangement of fibers with fiber-producing fibroblast and inflammatory cells, namely lymphocytes, along with silica-laden macrophages. In asbestosis, grossly, it affects pleura. There is thickening of the pleura and subpleural fibrosis. It affects the base of the lung. Microscopically, there is presence of concentrically arranged fibers with fiber-secreting fibroblast and inflammatory cells, namely lymphocytes. And most importantly, there are asbestos bodies. Asbestos bodies are nothing but dumbbell-shaped ferruginous bodies that is made up of the asbestos fiber, which is coiled or enwrapped by ferritin produced from macrophage. We are done with pneumoconiosis. By the end of this lecture, you will be able to answer all the questions, be it subjective or objective, under the topic of bronchogenic carcinoma. But then the first question itself is, what is bronchogenic carcinoma? Broncho refers to bronchi, bronchiole, and in this case, alveoli as well. Genic refers to generating from. And carcinoma is cancer arising from epithelium. So bronchogenic carcinoma refers to cancer generating from epithelium lining bronchi, bronchiole and alveoli. Or in more simpler terms, bronchogenic carcinoma refer to cancers arising from bronchi, bronchiole and alveoli. Or in even more simpler terms, bronchogenic carcinoma refer to lung cancer. But not just any lung cancer arising from respiratory epithelium present within the lung lining bronchi, bronchioles and alveoli. Okay. Now, if you flip through the pages of Robbins, you'll find a table classifying various bronchogenic carcinoma, which you can mock up for theory exam purpose. But right now, we are going to learn about the 4 most clinically significant or the 4 most commonly prevalent bronchogenic carcinoma. They are squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and large cell carcinoma. All I want you to do is take out your note, be it your physical note or digital note, make a table and start filling that table along with me. I assure you, once you know how to fill this table now, there won't be any question, any concept left behind. All you have to do is fill this table along with me. So let's begin. First things first. So what are the 4 most common or 4 most clinically significant bronchogenic carcinoma that you need to know? Squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and large cell carcinoma. The most common bronchogenic carcinoma is adenocarcinoma, followed by squamous cell carcinoma, then small cell carcinoma, then large cell carcinoma, then the rest. But at least remember, the most common bronchogenic carcinoma or the most common lung cancer is adenocarcinoma of lung. Okay. Prognosis. Small cell carcinoma has the worst prognosis. It is the most fatal out of all. One of the reasons also being that it shows the highest level of metastasis. So it shows maximum metastasis. Affiliation with smoking. Squamous cell carcinoma and small cell carcinoma have strong affiliation with smoking, which you can remember as SSS. So S for smoking, S for squamous cell carcinoma, and S for small cell carcinoma. Gross feature. So grossly, lung cancers have broadly 2 types. First, the central or hilar type is found in squamous cell carcinoma. The central or hilar type is also found in small cell carcinoma. In the rest, that is in adenocarcinoma, you have peripheral type. In large cell carcinoma, also you have peripheral type. So the letter C kind of sounds like S. So central, squamous, small, or just simply remember CSS. So the central or hilar type is found in squamous cell carcinoma and small cell carcinoma. Remaining is adenocarcinoma and large cell carcinoma, where peripheral type is found. Now, what is the main gross difference between central or hilar type and peripheral type? Let's see. This is the central or hilar type and this is the peripheral type. The obvious difference is in their location. So the central type is towards the center of the lung, so-called central type. Or it's towards the hilum of the lung, so also called hilar type. So location. It arises from the central bronchi. Remember, the central type or the hilar type arises from the central bronchi. Right here, the central bronchi. The peripheral type, called so because it's towards the periphery of the lung, and it arises from peripheral bronchiole or alveoli. Second difference, cot section. When you take a cot section of the central type tumor or the cot section of the peripheral type tumor, this is the difference you see. In central or hilar type, it is yellow-white. The cot section is yellow-white. The peripheral type, it is gray mucoid. So let's take an example. Let's say I ask you the gross feature of adenocarcinoma. You know that adenocarcinoma has peripheral type of lung cancer. That means it arises from peripheral bronchiole or alveoli and the cot section is gray mucoid. That's it. Another example. Let's say I ask you the gross feature of squamous cell carcinoma. You know that it is central or hilar type, so you can say that it arises from central bronchi plus the cot section is yellow-white. Another thing, the central type, as they grow, they can easily obstruct the airway, the bronchi, the primary bronchi, the secondary bronchi, leading to obstruction in airflow. Okay, next. Precursor lesion before invasion. See, all these carcinoma, they are cancers, and cancers are invasive in nature. But before the formation of this invasive cancer, there was a pre-existing lesion. Before the existence of this invasive form, there was a pre-existing non-invasive form. See. So there was pre-existing lesion which was non-invasive. Okay, within lung there was pre-existing lesion which was non-invasive, and this pre-invasive lesion which was non-invasive eventually converted into carcinoma which is invasive. So now you need to know for individual carcinoma what are the pre-existing non-invasive lesions. Okay, for example, squamous cell carcinoma. Again, little bit of concept, use concept, no need to mug everything up. Squamous cell carcinoma has what type of gross feature? The central or hilar type. Central or hilar type. That means it arises from central bronchi. Bronchi is lined by columnar epithelium, but the tumor is squamous. That means the columnar epithelium lining the bronchi is replaced by squamous epithelium. This is referred to as squamous metaplasia. So that is the precursor lesion. First there is squamous metaplasia. Everywhere you can use concept squamous metaplasia, which is then followed by squamous dysplasia, which is then followed by squamous carcinoma in situ. Still not invasive because it is in situ. Then this squamous carcinoma in situ first shows little bit of invasion, micro invasion, and then full-blown invasion. That is squamous cell carcinoma. All right. Second, adenocarcinoma. It has two precursor lesions, AAH and AIS. AAH stands for atypical adenomatous hyperplasia. Again, atypical adenomatous hyperplasia. AIS stands for adenocarcinoma in situ. AAH is less than equals to 5 mm in size. AIS is less than 3 cm in size. AIS is also referred to as BAC or bronchoalveolar carcinoma. So adenocarcinoma in situ is also referred to as bronchoalveolar carcinoma. Once again, let's look at both the precursor lesions of adenocarcinoma, that is atypical adenomatous hyperplasia and adenocarcinoma in situ, with the help of two pictures, histology, that has been given in Robbins. These two. So what did I say? There are two different precursor lesions that can eventually lead to adenocarcinoma of the lung. First is AAH, that is atypical adenomatous hyperplasia. Second is AIS, that is adenocarcinoma in situ. AAH is less than equals to 5 mm in size and AIS is less than 3 cm in size. Adenocarcinoma in situ is also referred to as BAC or bronchoalveolar carcinoma. Again, use another concept. See, adenocarcinoma, I said that what type of growth does it have? Peripheral. That means it arises from peripheral bronchial alveoli. Adenocarcinoma arises from peripheral alveoli. So if carcinoma is arising from alveoli, that means the precursor lesion has to be in alveoli as well. So that's exactly what's shown here. Bunch of alveoli has been shown here. Bunch of alveoli has been shown here. And this is the septa of the alveoli. This is the septa of the alveoli. The septa of the alveoli is lined by squamous epithelium to allow diffusion of gases. But in this case, since there is formation of precursor lesion, what happens? In atypical adenomatous hyperplasia, the septa is lined by cuboidal cells along with fibrosis. So there is cuboidal cell along with fibrosis. In case of adenocarcinoma in situ, the septa is lined by mucus-filled cells. It is lined by mucus-filled cells. See, if microscopically in adenocarcinoma in situ, there is mucus-filled cells and this adenocarcinoma in situ eventually leads to adenocarcinoma, then grossly, if you cut that section, what appearance is it gonna give? It is gonna give mucoid appearance. Simple logic. That is why in cut section of gross of peripheral type, I said gray mucoid array. Microscopy, in a microscopy, there are mucus filled cells. So in gross also, when you take a cut section of this, there is gonna be mucoid appearance because there is all that mucus there. Okay. Precursor. Third, small cell carcinoma. So according to Robbins, small cell carcinoma arises de novo from neuroendocrine cell. See, small cell carcinoma is a neuroendocrine tumor, and I've already taught neuroendocrine tumor in detail under carcinoids, under GIT pathology. And the advantage of knowing neuroendocrine tumor beforehand is that the basic features of neuroendocrine tumor or the basic characteristics of neuroendocrine tumor is same for all types of neuroendocrine tumor. That's the advantage. Okay. See, so small cell carcinoma is a neuroendocrine tumor. Neuroendocrine tumor is nothing but tumors that arise from neuroendocrine cell. So according to Robbins, small cell carcinoma is such a neuroendocrine tumor that has no precursor lesion, and it arises directly, all of a sudden, from neuroendocrine cells present in your respiratory epithelium, according to Robbins. But some studies, and even in Robbins under etiological factors, a precursor lesion for small cell carcinoma has been mentioned, and that is Dipneck. Dipneck. What is Dipneck? It is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. So before the formation of small cell carcinoma, there is a precursor lesion. That precursor lesion is hyperplasia of neuroendocrine cell. Obviously, because neuroendocrine cell tumor is small cell carcinoma, then first hyperplasia of neuroendocrine cell takes place, and then the neuroendocrine tumor, that is small cell carcinoma, forms. So there is hyperplasia of neuroendocrine cell that leads to small cell carcinoma. Where is hyperplasia taking? Within the lung. Because the neuroendocrine cell is within the lung. So pulmonary. The reason is not known. So idiopathic, and the hyperplasia is diffuse. So diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Again, there is hyperplasia of neuroendocrine cell within the lung or pulmonary, and the reason is not known. So idiopathic, and the hyperplasia is diffuse. So diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Large cell carcinoma, no precursor lesion. Okay, next, mutations. I can't be of much help for mutations. Now that you have to mug up on your own. There are lots of mutations given for each of the carcinoma, but at least remember the most important mutations. Squamous cell carcinoma, there is loss of 3p, 9p, and 17p, or there is TP53 and P53 mutation. For adenocarcinoma, the most common mutations are gain in function of EGFR, ALK, and KRAS. For small cell carcinoma, in almost all the cases of small cell carcinoma, there is loss of 3p. Okay. Next, immunohistochemistry or tumor marker. Squamous cell is P50 positive and P63 positive. Adenocarcinoma is thyroid transcription factor 1 positive and napsin A positive. Small cell carcinoma. Again, I said that small cell carcinoma is a neuroendocrine tumor, and it is a great advantage that you know neuroendocrine tumor beforehand. This is the reason why. Small cell carcinoma shows all the neuroendocrine tumor markers. So if you know what neuroendocrine tumor markers are, it is going to be positive for all of them, right? So what are the neuroendocrine tumor markers? There are 3 INS and 3 letters and numbers. What are the 3 INS? Synaptophysin, chromogranin, and bombesin. 3 letters and number: NSE, CD56, CD57. Again, total 6 neuroendocrine tumor markers that are positive for all neuroendocrine tumors, be it small cell carcinoma of lung, be it carcinoid of the lung, it's the same for all neuroendocrine tumors. The 6 neuroendocrine tumor markers, they are 3 INS, synaptophysin, chromogranin, and bombesin, and 3 numbers and letters, NSE, CD56, and CD57. Good. Large cell carcinoma. It shows a diagnosis of exclusion. What does that mean? It means that you diagnose a patient with large cell carcinoma when all other possibilities are excluded out. That is, if there is no squamous cell carcinoma, there is no adenocarcinoma, there is no small cell carcinoma, then most probably it is large cell carcinoma. So diagnosis of exclusion, that is diagnosed when all other possibilities are excluded out. Paraneoplastic syndrome. Squamous cell tumor, it produces parathormone, which leads to hypercalcemia. Adenocarcinoma tumor secretes procoagulants, which leads to Trousseau phenomenon, which is seen in migratory phlebitis. The reason I have broken the whole terminology is to explain that itis means inflammation. Phleb comes from phlebo meaning vein. Thrombo refers to thrombus. And migratory refers to traveling. So in migratory thrombophlebitis, there is inflammation of vein along with the formation of traveling thrombus within the vein. And this phenomenon of frequent formation of thrombus in different sides of the body in vein is referred to as Trousseau phenomenon. Why is it taking place? Adenocarcinoma tumor of the lung is continuously producing procoagulant. Procoagulant factors, they promote coagulation, promote the formation of thrombus. That is why at different sites within your body, within your vein, there is formation of thrombus. And this is referred to as Trousseau phenomenon, which is associated with migratory thrombophlebitis, where there is inflammation of the vein along with the formation of traveling thrombus within the vein. Small cell carcinoma. It produces ACTH and ADH. Too much ACTH leads to Cushing's syndrome. Too much ADH leads to SIADH. Simple, SIADH means it's a syndrome of inappropriate secretion of ADH. SIADH, syndrome of inappropriate secretion of ADH. There is, after all, inappropriate secretion of ADH due to the formation of the tumor. The tumor is secreting ADH. It's not physiological ADH. It's being secreted by the tumor. Small cell carcinoma can also lead to Lambert-Eaton syndrome. Okay. Large cell carcinoma. It produces estrogen/progesterone, which can lead to gynecomastia in male. Gynecomastia in male. Okay. Next. Okay, finally, really important. Something as a pathologist or a student learning pathology you must know, and that is the histopathology. What is there? Squamous cell carcinoma, adenocarcinoma, small cell carcinoma, large cell carcinoma. First, squamous cell carcinoma. In squamous cell carcinoma, microscopically, you get to see two things. Number one, keratinization, that is deposition of keratin. If the deposition of keratin takes place within the tumor cell, which is intracellular keratinization, and outside the tumor cell in the matrix, that is extracellular keratinization. Due to deposition of keratin within the tumor cells become eosinophilic. So eosinophilic tumor cells. Eosinophilic tumor cells. So for each histopathology, I am using two diagrams. Number one, this is from Horstmann and this is from Robbins. So the Robin is obviously the accurate representation, what you see under the microscope. And Horstmann is the one that you can draw in your exam. So see in the Robbins histology, okay, there are these cells that appear bright red in color. Why? Because they are highly eosinophilic. They are eosinophilic because there is deposition of keratin in them. So these are the tumor cells inside of which keratin deposition has taken place. Second, due to extracellular deposition, there is whirling of the tumor cells leading to formation of keratin pulse. Keratin pulse. See here, there is whirling of the tumor cells leading to formation of keratin pulse. See here, whirling of the tumor cells, whirling of the eosinophilic tumor cells leading to formation of keratin pulse. Second, there is also presence of intercellular breezes. So in exam, when you draw, this is what you need to draw. First, draw the tumor cell. Draw them highly bright pink because they are eosinophilic due to the deposition of keratin in them. And then draw intercellular breezes in between them. Make some of the tumor cell in whirling pattern, that is due to keratinization outside the cell in the matrix, forming keratin pulse. That's it. Second, adenocarcinoma. Now, adenocarcinoma is found in various patterns like acinar, which is glandular pattern. Solid, that is the tumor cells are arranged in sheets, plain sheets. Papillary, that is the tumor cells they are arranged in finger-like projection. And micropapillary, that is the tumor cells are arranged in pseudopapilla. Pseudopapilla. What's the difference between papilla and pseudopapilla, or what's the difference between papillary arrangement of tumor cell and micropapillary arrangement tumor cell? In a papillary arrangement, the tumor cells are arranged in finger-like projection along with a fibrovascular core. In a micropapillary arrangement, the tumor cell is arranged in finger-like projection, but there is no fibrovascular core. Good. Another very important pattern is a Lepidic pattern. I'll explain what Lepidic pattern is. Wait. So what is this? This is the microscopy of immunohistochemistry. And all these darkly stained cells that you see right here, they are the tumor cells. And the reason these tumor cells are darkly stained is because of the presence of tumor marker in them. In adenocarcinoma, what is the tumor marker? I taught you two, thyroid transcription factor 1 and napsin. In this immunohistochemistry, we are looking at darkly stained tumor cells due to the presence of thyroid transcription factor 1. Okay. Lepidic pattern. Okay. See, very first I taught you that adenocarcinoma is which type? It is a peripheral type. That means it arises from peripheral alveoli. So the tumor is arising from alveoli. So the Lepidic pattern is obviously going to be in alveoli as well. Your alveoli is normally lined by squamous epithelium. However, in adenocarcinoma, that squamous epithelium is replaced by cuboidal to columnar epithelium, and this is referred to as Clara cells. What are Clara cells? These are cuboidal to columnar cells lining alveoli that produce mucin. So these Clara cells, they produce mucin. Do you remember something? In the precursor or the pre-existing lesion of adenocarcinoma, that is adenocarcinoma in situ, I said that the alveoli is lined by mucus-filled cells. These are not Clara cells. These are the mucus-filled cells in adenocarcinoma in situ. When this adenocarcinoma in situ eventually develops into adenocarcinoma with Lepidic pattern, Then the alveoli is lined by Clara cells. These Clara cells are cuboidal to columnar and they produce mucin. Okay. Then small cell carcinoma. Again, the advantage of knowing neuroendocrine tumor beforehand. I've already taught you neuroendocrine tumor under carcinoid of GIT pathology. So the microscopy or the histopathologic features are going to be the same for almost all neuroendocrine tumors. So in neuroendocrine tumor, what do you get to see are small, round, blue cells with indistinct border. See, the cells are small, they are round, and they are blue, and the border is not distinct. So these are actually the nucleus of the cell. The outer border, it is not visible. So the reason the cells are small, round, and blue is due to the presence of large blue nucleus, with less or scanty, barely there is any cytoplasm, scanty cytoplasm. Plus there are areas of necrosis as well. This is important as well. There is necrosis. Okay. Now, this is from Robbins. This is from Horsemohan. This is from Robbins. This is from Horsemohan. Just so you know the source of the images. All right. If I zoom into individual tumor cell, you can see that there is granular pattern that is present. Individual tumor cell, there is granular pattern that is present. What type of granular pattern? So there is dark granule and there is white granule. Dark granule, white granule, dark granule, white granule. It seems as if there is pepper on top of salt, giving salt and pepper appearance. That is due to the presence of fragmented chromatin material, giving that dark fragmented appearance on top of white background. So this gives salt and pepper appearance of cell. Previously, small cell carcinoma was also referred to as oatmeal carcinoma. The reason being, the tumor looks as if there are looks like a oatmeal. That is, you take a bowl of milk and then put oat on top of it. So that's the appearance it is giving off. Okay, oatmeal appearance. Another thing, what do you see right here is the wall of a blood vessel, and the wall of the blood vessel appears really blue or basophilic. Why? This is the reason why. I said that the necrosis part is important, right? This is why. Due to the necrosis of the tumor cells, the DNA from inside the tumor cells leaks out. And these DNA, they stick on blood vessel wall. As a result, the blood vessel wall, it appears blue or basophilic. This effect is referred to as Azopardi effect. Very important, Azopardi effect. So few important terminologies. Number one, salt and pepper appearance of individual tumor cell. Number two, oatmeal carcinoma referring to small cell carcinoma. Number three, Azopardi effect. What is Azopardi effect? Due to necrosis of these tumor cells, the DNA from inside the tumor cell, it leaks out. This leaked DNA goes and sticks on the wall of the blood vessel. As a result, the wall of the blood vessel appears blue or becomes basophilic. This is Azopardi effect. Large cell carcinoma, it is quite the opposite of small cell carcinoma. So here you have large tumor cells with distinct border and distinct nucleoli. Sometimes giant cells might even be visible. Giant cells, depending on the type of large cell carcinoma. Other than that, large cell carcinoma is not that important. So now you know the microscopic features of all four carcinoma. One last revision. Squamous cell carcinoma, there is keratinization. Inside the cell, intracellular keratinization leading to highly eosinophilic tumor cell. Outside cell, extracellular keratinization leading to the formation of keratin pulse. Plus, in between tumor cells, there are presence of intercellular bridges as well. Adenocarcinoma present in various pattern like acinar referring to glandular pattern, solid referring to tumor cells arranged in sheet, papillary referring to tumor cells arranged in finger-like projection, micropapillary referring to tumor cells arranged in pseudopapilla. The difference between papillary and micropapillary or papilla and pseudopapilla is that in papillary there is fibrovascular core in between the papilla. In pseudopapillary or micropapilla there is no fibrovascular core within the papilla. Then there is the Lepidic pattern. In Lepidic pattern, the alveoli is lined by Clara cells. Clara cells are cuboidal to columnar cells lining the alveoli that produce mucin. Small cell carcinoma, it's the same as neuroendocrine carcinoma, where you see small round blue cells with scanty cytoplasm, indistinct border and large nucleus, plus there is necrosis as well. Due to necrosis, the DNA from inside the cell leaks out. The DNA from inside the tumor cell leaks out. It goes and sticks on the wall of the blood vessel, making it basophilic. This is referred to as Azopardi effect. If you look at individual tumor cell, it gives salt and pepper appearance. The carcinoma, the small cell carcinoma, was previously also referred to as oatmeal carcinoma. Then large cell carcinoma, there are large cell with distinct border, distinct nucleoli, and sometimes giant cells may also be visible. Okay. Finally, metastasis. In Robbins, it has been written that in more than 50% of the cases, or almost 50% of the cases, long tumor metastasizes for some reason to adrenal gland, where the adrenal gland. Then following that is liver, brain, bone. But then in 50% of the cases, long tumor metastasizes to adrenal gland. Pneumonia is the infection of long parenchyma. What is long parenchyma? Long parenchyma includes alveoli, bronchi, bronchioles, blood vessels, basically all those structures that make up the mass of the lung. And the infection of this mass of the lung is pneumonia. See, pneumonia is a really easy topic if you know the basic concept from general pathology, because you are going to use your concept about infection, your body's ability to fight against this infection, and most importantly, the various steps that you learned under the topic of inflammation. That is why first I'm going to give you a small recap of the concepts of general pathology that you need to know so that you can understand pneumonia. Now again, whatever I'm going to show you right now is something that you must already know. But I know that as medical students, we don't remember much, do we? That's why a small recap of the general concept. See, whenever there is infection, this leads to injury. And when there is injury to vascular tissue, this leads to inflammation. And what happens during inflammation? What are the steps of inflammation? Very first, there is vasoconstriction. There is transient vasoconstriction, which is followed by vasodilation. Persistent, that is lasting for a longer period of time, persistent vasodilation. Now the blood vessel that is dilated, there is accumulation of blood. Due to accumulation of blood, there is increase in hydrostatic pressure. Due to increase in hydrostatic pressure, the fluid from inside the blood vessel gets pushed outside. And this fluid is referred to as transudate. Transudate contains little to no cell. When fluid from inside the blood vessel gets pushed outside, where will it go? It will go to various spaces that it finds, and it will lead to swelling. And swelling is referred to as edema. Here, since the edema is due to transudate, this is transudate edema. So first, what happens? Due to dilation of the blood vessel, there is increase in pressure within the hydrostatic pressure within the blood vessel. This leads to fluid being pushed out of the blood vessel. This fluid contains little to no cell, so it is referred to as transudate, and transudate leads to transudate edema or transudate swelling. Immediately following that, what happens? The permeability of the blood vessel increases. The permeability of the blood vessel increases. Now, it's not just fluid that comes out. Now even cells comes out. RBCs come out. WBCs come out. Fibrin come out. The WBCs that come out first are neutrophils or polymorphonuclear cells. And when the inflammation takes place for a longer period of time, that is chronic, then comes out lymphocytes. Okay. Now this substance that comes out of the blood vessel due to increase in permeability of the blood vessel that contains fluid plus lots of cells is exudate. This is exudate, and the swelling due to exudate is exudate edema. Okay, this is the basic of the basic thing that you must already know from general pathology that you need to recap here right now. If nothing, at least remember, at least this much keep in your mind, that when there is inflammation, there is dilation of blood vessel, due to which transudate comes out. Transudate contains fluid, not cells. Later, due to increase in permeability, along with fluid, cells come out. This is exudate. So transudate contains fluid with no to little cells. Exudate contains fluid along with lots of cells. The cells are red blood cells and white blood cells. The white blood cells that comes first during acute period of time is neutrophil, and the white blood cells that come later after chronic period of time is lymphocyte. Okay, now finally, let's get into the itty-gritty stuff of pneumonia. What is pneumonia? Pneumonia is infection of lung parenchyma. What happens when there is infection? Dilation of blood vessel takes place. As a result, what leaks out of the blood vessel? First transudate, then exudate. Now see, within your lung, if exudate comes out of the blood vessel, where will it go? It will go to every empty space that it finds and goes and fills there. Now there are two types of empty space: interstitial space or intraalveolar space. See here, within your lung parenchyma, there is alveoli. And there is blood vessel as well. Now due to injury to blood vessel, it dilates. The hydrostatic pressure inside the blood vessel increases, and what comes outside is transudate. Later, the permeability also increases. So what comes out is exudate. Now this transudate, exudate, they have to go somewhere now. Where will they go? They will go and fill up the empty spaces inside the lung. There are two empty spaces. One is the interstitial space present in between the alveoli, and the other is the intraalveolar space present within the alveoli. So the fluid goes and fills up either the interstitial space or the intraalveolar space. Once it goes and fills up the space of the lung becomes form, Clara, and this is referred to as consolidation of lung. See, very easy analogy. You have a balloon, and this balloon is filled with air. That's your lung right now without pneumonia. Now you take the same balloon and fill it with water. That's your lung in case of pneumonia. In case of pneumonia, the empty spaces inside the lung gets filled with water-like substance. And this filling of the empty spaces inside the lung is consolidation. Okay, so what is there? There is infection of lung parenchyma, which leads to inflammation. Due to inflammation, fluid leaks out and fills up the empty spaces of the lung. That's called consolidation. So this is the definition of pneumonia. Pathogenesis. Very easy. Why is pneumonia taking place? Due to infection. Whenever there is infection, your body tries to fight against it. If your body wins, hooray, you are healthy. If your body doesn't win, the infection wins and you have pneumonia. That's it. Pneumonia is caused by microorganism causing infection. Let's say this microorganism enters your body via any route, be it through inhalation, through blood, hematogenous, direct spread, whatever be the route. The microorganism enters inside your body. Once the microorganism enters inside your body tries to fight against it. It tries to fight against it. If your body wins, you don't get infection. But if the microorganism wins, you get infection. So the reason behind pneumonia is that your body does not win the fight. It does not win the war. So the pathogenesis is impairment in pulmonary antimicrobial defense mechanism. That is, your body defense mechanism is impaired. As a result, it is unable to fight against the microorganism, leading to infection. Now, defense mechanism is of two types. There's systemic defense, and then there is local defense. Systemic defense means what? Once the microorganism enters the body, once the microorganism enters the body, first your whole body tries to fight against it, right? It's not just your lung, trachea, bronchi, bronchial, not just the respiratory system. It's your body also trying to fight against it. That is your systemic defense. That is basically your immunity trying to fight against it. So if your immunity is impaired or the systemic defense is impaired, obviously the infection wins. Local defense includes long defense mechanism. Now this is more specific to your respiratory system. All the defense mechanism that your respiratory system follows to fight against infection, that's long defense mechanism. And this is a huge topic of its own that you need to study under physiology. So under physiology, you study about long defense mechanism, various ways the long defense against microorganism, and then in each step impairment can lead to pneumonia. So a decrease in long defense mechanism leading to decrease in local defense, leading to infection and then pneumonia. Okay. Now the more important part of the lecture, and that is classification, the types of pneumonia. First, on the basis of clinical setting. So here's a huge table given in Robbins. Do as you please with it. Second, on the basis of causative agent or etiology. At the end of the day, pneumonia is infection caused by microorganism. Now, if this microorganism is bacteria, the pneumonia is bacterial. If it is virus, the pneumonia is viral. If it is parasite, the pneumonia is parasitic. And if it is fungi, then the pneumonia is fungal. Another, on the basis of anatomic reason, there are three types of pneumonia. They are interstitial pneumonia, lobar pneumonia, and lobular pneumonia. Okay, hear me out first. Hear me out. I said that whenever there is pneumonia, there is consolidation of the lung. Why? Why does consolidation of the lung takes place? It takes place because the empty spaces inside the lung gets filled up with exudate. There is inflammation. So the content from inside the blood vessel leaks outside, right? Exudate comes outside, exudate goes and fills up the empty spaces. I said there are two empty spaces: intra-alveolar space, the space inside the alveoli, and interstitial space, the space in between the alveoli. If it is the interstitial space that gets filled up with exudate, the interstitial space that gets filled with exudate, then this pneumonia is atypical pneumonia. But if it is the intra-alveolar space that gets filled up with exudate, then this is typical pneumonia. In atypical pneumonia, since it is the interstitial space that gets consolidated by exudate, it is also referred to as interstitial pneumonia. So this is the first type of pneumonia on the basis of anatomic region. Under typical pneumonia, you have again two types. If it is a huge chunk of lobe or the complete lobe of a lung that is consolidated, then that is lobar pneumonia, the second type. But if there is patchy involvement, That is only certain patches of lung is involved, right? Certain patches of lung is involved. That is either the lobule of the lung or the bronchi and bronchiole of the lung. Then we call that lobular pneumonia or bronchopneumonia. Bronchopneumonia. Again, in more detail. So you have two types of pneumonia. If it is the interstitial space that is filled with exudate, atypical pneumonia. If it is the intra-alveolar space that is filled with exudate, typical pneumonia. So atypical pneumonia, exudate is in interstitial space. Typical pneumonia, exudate is in intra-alveolar space. Cough. When you cough, what happens? Whatever content is present within the respiratory tract, within the alveoli, gets pushed outside due to pressure difference. It gets pushed outside. In atypical pneumonia, since there is no exudate inside the alveoli or the alveoli is empty, the cough is dry, nothing comes out. But in typical pneumonia, the intra-alveolar space is filled with exudate. So when you cough, this gets pushed out of the mouth as well. So the cough is productive. Etiology. Typical pneumonia is due to bacteria. And there are three important bacteria that you need to know the name of. Remember the name of. Streptococcus pneumoniae, Klebsiella pneumoniae, Haemophilus influenzae. Atypical pneumonia, on the other hand, is usually due to virus. For example, measles. But there is an exception. One bacteria by the name of Mycoplasma also causes atypical pneumonia. Mycoplasma causes something called walking pneumonia. What is walking pneumonia? Walking pneumonia, it's a type of pneumonia caused by Mycoplasma where the symptoms are not that severe. So the patient can simply walk to the hospital. So walking pneumonia. Measles causes Hecht's pneumonia. What? Hecht's pneumonia. Hecht's pneumonia. Under typical pneumonia, again you have two types. If the consolidation of the complete lobe or a large part of the lobe of the lung takes place, that's lobar pneumonia. So if it's the lobe that gets consolidated, it's lobar pneumonia. If it's lobule that gets consolidated or bronchi bronchioles that get consolidated, it's bronchopneumonia or lobular pneumonia. Under lobular pneumonia, you need to remember the 3 B's of lobular pneumonia. They are B for basal. As you can see, the involvement is of the base of the lung. So basal. B for bilateral. As you can see, both the lungs have been involved. So bilateral. And B for bimodal. That is, it is found in both extremes of the age, in young people as well, in old people as well. Okay. Now, Laennec stages of lobar pneumonia. I don't know why lots of students find this difficult, because if you just know the steps of inflammation, this is done, brother. See, if you just know these steps, it's the same copy paste of these steps. Laennec stages of lobar pneumonia. So it is divided into 4 stages. Number 1, congestion. Number 2, red hepatization. Number 3, gray hepatization. And number 4, resolution. Remember, the total time duration for all the stages is 10 days. Now, you need to remember for individual stage how long they last. Very easy to remember. Hear me out. Congestion starts in the first day, multiply by 2, 1 to 2 day. Red hepatization in 2 day, multiply by 2, 2 to 4 day. Gray hepatization in 4, multiply by 2, 4 to 8 days. Resolution in 8, it's a total of 10 days, so 8 to 10 days. Done. Congestion 1 to 2 day, red hepatization 2 to 4 day, gray hepatization 4 to 8 days, and resolution 8 to 10 days. Done. Okay. Now, each stage. First, congestion, which lasts from 1 to 2 days. I said during inflammation, what happens? During inflammation, what is happening? Hear me out. We are learning about the lanic stages of lobar pneumonia. Lobar pneumonia, that means a complete lobe of a lung or a huge part of the lobe of a lung is consolidated. So trace the lobe of the lung. Trace this lobe. 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 Okay, what is happening to the lobe? Second thing, lobar pneumonia is a typical pneumonia. That means the exudate is present inside the alveoli in the intra-alveolar space. So trace this. Here is alveoli. Here is alveoli. Here is alveoli. Inside the alveoli, you are supposed to have air space, but now there is no air space. It is filled with something. What is that something? Hear me out. Okay. So the first step is congestion lasting from 1 to 2 days. There is infection. Due to infection, there is inflammation. Infection, then inflammation. In inflammation, the dilation of the blood vessel takes place. As a result, there is increase in hydrostatic pressure. As a result, the fluid from inside the blood vessel gets pushed out, and this fluid is nothing but transudate. And transudate contains little to no cell, and the edema due to transudate is transudate edema. So see here also, here is the blood vessel. There is engorgement of the blood vessel or the dilatation of blood vessel, due to which there is increase in hydrostatic pressure. So the fluid from inside due to pressure difference gets pushed outside. Where does this fluid go? This fluid goes and it accumulates in the air space within the alveoli. So the air space is now replaced with transudate. It is replaced with transudate. So if I had to label it, I'll write two things. Number one, there is engorgement of blood vessel, and number two, the alveoli is filled with the air space. The air space is filled with transudate. Okay, so what will happen to the lung grossly? You have a balloon filled with air. You have the same balloon filled with water. Which is heavier? Obviously, the balloon filled with water is heavier. Here also, previously there was air space, but now this air space has been replaced by fluid, water-like substance. So the lung becomes heavy, weight, boggy. So you get boggy and heavy lung. Boggy and heavy lung. Second, red hepatization from 2 to 4 days. Okay, now after dilation, after hydrostatic pressure increase, there is increase in permeability. Due to increase in permeability, now not just the fluid comes out, now cells also come out. The cells include red blood cells, white blood cells, as well as fibers come out from within the blood vessel. You can see white blood cells, red blood cells. Which white blood cells come out first? Neutrophil or the polymorphonuclear cells. So you can see all the polymorphonuclear cells right here. Due to the leakage of red blood cells from inside the blood vessel, that red blood cell is filling the alveolar spaces now. So the lung appears red. The lung appears red. It is red. The air that was inside the alveoli is now completely replaced by cells. As a result, the lung becomes form like liver, so called hepatization. That is, first the lung was like sponge, but now as the air spaces are filled with cells, it has become form like liver. The process is called hepatization, becoming like liver. So this step is called red hepatization. Red due to red blood cells, hepatization due to conversion of the spongy lung into form lung. Okay. Third, gray hepatization. All the RBCs that came into the alveolar space, they become old, they die, and they get eaten up. So all the RBCs are now eaten up. What remains? The WBCs, the polymorphonuclear cells, and the fibers remain. The WBCs and the polymorphonuclear cells or the fibers remain, and they give lung the gray color. Which color? Gray color. See, the air space is still filled with cells, Previously, the cells were red blood cell WBCs and fibers. Now it's just WBCs and fibers. RBCs are not there. So since the airspace is still filled with cell, the lobe of the lung is still formed, Clara, like liver. So this is called hepatization. So the name gray hepatization. All right. Now, finally, all the cells that were present within the alveolar space get eaten up or digested by the enzymatic action. So the enzymes get produced, the cells get eaten up. Now all remains are the pieces of the cell, the debris, dhulo, the debris of the cell remain. And the cells that come later on, what are they? The lymphocytes. So the lymphocytes are there. Neutrophils come first, lymphocytes come later. So now you have lymphocytes and debris after all the cells have been digested. This is the phase of recovery, also referred to as resolution. So from 8 to 10 days, resolution takes place. That's the Laennec stages. One last revision of Laennec stages. First, you have congestion. In congestion, due to increase in hydrostatic pressure due to dilation of the blood vessel, transudate comes out, and the transudate goes and fills up the air spaces. So there is engorgement of the blood vessel and filling up of the air spaces by transudate. Since the lobe is now filled with water-like substance, it is heavy and boggy. Similarly, after that, there is increase in permeability of the blood vessel. As a result, along with fluid, cells also come out. These cells are red blood cells, white blood cells, and fibers. Due to red blood cells within the alveolar space, now the lobe of the lung is red in color, so red, and the lobe of the lung is firm in consistency because the air space is now filled with cells, solid stuff. So it is formed like liver, called hepatization. So together, red hepatization. After that, all the RBCs get eaten up. What remains are only WBCs, the polymorphonuclear cells or neutrophils, and fibers that give the gray color. Since the air space is still filled with cells, solid substance, so it is still formed like liver, so gray hepatization. Finally, all the cells, they get digested by the digestive enzyme and only the cell debris remain, and the cells that come later on in the chronic stage, the lymphocytes come. This is a phase of recovery, also referred to as resolution. And we are done with pneumonia as well.